I want to welcome all of our attendees today for the Gloderm Training Committee educational webinar. We have two incredible speakers, Dr. María Sáenz and Dr. Doreen Mapunda, and they'll be discussing vascular anomalies and infantile hemangiomas. For some basics about the Gloderm Training Committee, your host today will be myself, Alexa Reese, and then Fortunate Raymond Makoe, who will be helping to answer any questions in the chat. GTC, or the Gloderm Training Committee, is part of Gloderm, which is the International Alliance for Global Health Dermatology, with a mission to promote knowledge equity by enhancing access to dermatology education worldwide. These educational webinars are just one of the few key initiatives of this committee, alongside networking and collaboration and the new podcast series. For some basic meeting etiquette, your audio will be muted and your camera will be turned off. If you have any questions, please submit them in the chat and the Q&A function below. And at the end of the webinar, our hosts will share these questions with the speakers and they can answer them at the end. Additionally, we'll be sharing any information about the training committee in and of itself in the chat function. So if you have generic questions about that as well, please ask them there. I have the pleasure of introducing our speakers, Dr. María Sáenz and Dr. Doreen Mapunda. Dr. Sáenz is an associate professor of dermatology and a chief of pediatric dermatology at the Hospital Universitario de Caracas. She was a recent Gloderm mentor this past year, and she specializes in vascular anomalies clinic, with her work dedicated in dermatology over the past 30 years in the same institution, which is incredible. Additionally, Dr. Doreen Mapunda is a dermatologist and venerologist in Arusha, Tanzania. She just graduated from the Gloderm mentorship program as a mentee to Dr. María Sáenz, and her interest in global health dermatology and pediatric dermatology will really be highlighted here. So I thank you both for your time and attention and sharing your knowledge about vascular anomalies. And with that, I'll let you guys take away the stage.
Hello. Thank you for that wonderful introduction, Alexa. I hope everyone can hear me. Good day to all of you. Thank you for joining us. I will be presenting the case for this presentation. And our case is about a male baby who presented at the dermatology outpatient clinic at 3 months of age. His mother reported facial redness from the 3rd day of life, which worsening for the past 2 months. Okay. So yes, I'll start over. Our case presentation is of a male baby presented at the dermatology outpatient clinic at 3 months of age. His mother reported facial redness for the past 2.5 months, which started on the 3rd day of life and had been worsening for the past 2 months. She also did not report anything on the pediatric history because our baby was a term baby born at gestation age of 39 weeks with an APGAR score of 9 to 10 and a body weight of 3 kilograms, and no other symptoms were reported. So these pictures on the screen are courtesy of our patient's mother. She gave us the picture on the left, showing the first day she noticed the facial redness. As you can see, the baby was 3 days old, and the right side of the face has a bit of redness. And the one on the right is of the baby when he was 6 weeks old, and the redness had gotten worse. You can see you can see it better in the picture on the right. So we did a physical examination on the day that this child presented, and we noticed a red to violaceous plaque on the right side of the face, spreading from the forehead to the periorbital region down to the cheeks and the nasolabial fold. And it was a pulsatile blanching lesion. There was no ulceration, no crusting, and no active bleeding. And full body examination revealed no other hemangiomas or any other lesions. And this baby was actually a referral from the pediatric unit, and together with the pediatricians, we had done a full body exam, and all the other systems were normal. And we also called in the ophthalmologist for a review, who reported a normal ophthalmology exam. The picture on your screen now is the picture that was taken on the day that the baby presented to the dermatology clinic. As you can see, the red to violaceous plaques spreading from the forehead down to the cheek, and you can see on the eyelids, the upper and lower eyelids, the lesion is thicker, the color is deeper than the rest of the lesion on the face, compared to the part on the forehead and the part on the cheek. So with this presentation, we thought of a segmental infantile hemangioma and mixed type because, as I mentioned before, the forehead and the cheek, you can see it's superficial, but the lesion on the eyelids, it shows a bit of a deeper hemangioma. So this is a mixed presentation, and because of the position of the hemangioma, we had to think of Faces syndrome. So Faces syndrome, Dr. Ana Maria will explain to us more about what Faces syndrome is, but basically, segmental hemangiomas on the face may have involvement of arteries in the brain and sometimes also in the heart. And so our investigations included an echo to check the heart and abdominal ultrasound, which were all normal. So the gold standard investigation would have been an MRI, but at our center at that time, we were not able to do an MRI. So from the clinical presentation, we decided to start the baby on treatment, and with oral propranolol, and we did 3 milligrams 12 hourly. And our patient came in 2 weeks later. The picture on the left shows the progress. He was doing so much better. There was reduction of redness, and even the lesion on the eyelids was getting smaller, and the baby could now open the right eye. And then again, we saw the patient a few months later, and the picture on the right is when the patient was 7 months old. Thank you. That is the end of my case. I welcome.
Thank you for sharing those cases. That was really interesting. Dr. Ana Maria, please share your screen. I'm excited to hear what you have to share your knowledge with us.
Hello, everybody. Can you hear me?
Yes, we can hear you.
Yeah, all right. So very good case, Doreen. It was very representative, and we are going to learn from it a lot today. And thank you, GLODERM training committee, for this invitation in this nice theme like the vascular anomalies, which is very interesting, and a lot of dermatologists and residents like to know about this topic very much. So vascular anomalies, let me see if I can pass now. Okay. I'm going to talk about generally what is a vascular anomaly. These are morphogenetic defects of the vascular system. The vascular system is composed of arteries, capillaries, veins, and lymphatics. So it could be any of them. They could appear individually or in combination, complex combinations. Its general prevalence is around 4.5%, and it could present in a wide spectrum of clinical presentations in simple birthmark to life-threatening conditions that we have seen, and also some of them, although focal, they could impact very much the quality of life of our patients. So dermatologists and also pediatricians and general doctors are the ones that see these cases first. So it's good that you have a general idea of what lesions mean and what you have to do to make their life better and to resolve the situation better. So long time ago, since when I first studied dermatology, it was very confused to talk about the vascular anomaly. There was a diverse terminology. Everybody speak different terms, different definitions. And since 1992, with the creation of the International Society for the Study of these lesions, vascular anomalies, which is called the ISVA, which I invite you to visit the page, because the web page, it has all the information, some are free for you to see, to take a look, very interesting. So since the creation of this association, they tried to put things together in the same way, in the same language for everybody to understand all over the world and to get everything organized and finish that mess in everything. So they have created the last classification since 2024, and now is proposing this year in the last meeting. The vascular anomalies are classified into vascular tumors, vascular malformations, and the potentially unique vascular anomaly. So in the vascular tumors, we have the benign tumors, where is the infantile hemangioma is located. But I wanted you to visualize this classification. You can get organize your mind, and then you understand better. So vascular tumors are considered proliferative lesions. I mean, there's growth, there's proliferation, and vascular malformation, there's no proliferation, right? So that's a difference. So in the benign vascular tumors, we have the infantile hemangioma, and then we have the congenital hemangioma, tufted angioma, and other, that's a list. We have the borderline, which we have caposiform hemangioma, and we have the malignant, an example, for example, angiosarcoma. So these are the images that I want you to remember. So what are the infantile hemangiomas? Are the most common soft tissue tumors of infancy. That's why we have to get to know it very well. They are not born with this lesion. They arise the first weeks of life. You could see it in the case that presented Doreen, that the baby showed the lesion days after he was born. So they rise the first weeks of life. Then they display a period of active growth, followed by a spontaneous involution. If you take a biopsy, you will see there's a proliferative epithelium. I mean, a lot of capillaries growing there. So you see this picture, a baby with little telangiectatic macule, and then all of a sudden it starts this plaque that grows so fast that ulcerates very quickly. So it has a prevalence around 4 to 5% in mature neonates, and has a predominance for female and also white skin. So it increases in low birth weight and decreasing gestational age. 23% in premature babies, as you see, is more in premature babies than 1,000 grams birth weight. They are also associated in families with history of infantile hemangioma, and also in those ladies that have complications during the gestation, like eclampsia or placental anomalies, or are in progesterone therapy, or they have multiple gestation. And also they have been associated with maternal smoking, other maternal age, in vitro fertilization, amniocentesis, chorionic villus sample, etc. So clinically, they have different patterns that makes you easy diagnosis. For example, they are focal, multifocal, we're going to see some samples, segmental, or indeterminate. And we have also different types according to their localization in the skin, in superficial, deep, mixed, which have both components, reticular, abortive, or minimal growth, and others. And the hemangioma could be associated with another lesions. So we have the syndromatic of lesions that are called faces syndrome and lumbar, which is synonymous sacral or pelvis syndrome. And later on, I will show you some pictures. So the superficial lesions are these characterized by these papules, plaques, or nodules that are bright red color, and they look like that because they are upper in the dermis, in the upper side. So you see these characteristic lesions. Then we have the deep, which are extended to the adipose tissue and can be present as bluish tumors and indistinct borders. And they sometimes appear later on, 2 or 3 months after birth, some of them, that can confuse you with another type of tumor. So then we have the mixed ones that are mixed components, superficial and deep component together. We are not the most frequent one. The most frequent ones are the superficial. And then some of them can get a configuration called segmental. They take a dermatome completely. You can see it like this on the face or in the trunk, and they have this shape, very characteristic, that will tell you, advise you of possible association with another lesions outside the skin. And then you have the multifocal, which are a lot of hemangiomas all over the skin. It could be more than 5, and you can call them multifocal. Right? So the natural history of the hemangiomas is growth rapidly in the beginning, and then stop growing, and then becomes an involution. It's not a linear growth. It's sometimes is very fast, sometimes others not so fast. But usually the most time that they grow is around the 3 months with 5 to 8 weeks of life. They say in the papers that 80% of the absolute growth is completed by the age of 3 months. And the segmental and deep hemangiomas continue to grow until the 9th to the 12th month of life. In rare cases, to the 24th, until the 2 years of age. As you can see in this graph, most of them grow on the 3 to 4 months, 80% completely, 9th month maximum size, and then they start to involute, and mostly in the year 4, 5 years, they are completely regressed, 80% of them. This is an example of superficial hemangioma that if you look the 2003 and then 2004, 1 year later, almost disappear. You can see a telangiectatic tissue on the place where this was this hemangioma. So usually there's a period of relative stabilization, but a spontaneous regression over several months of years. As I told you, there are some cases that around 4 years, but there are others that have late proliferation, and there are others that have abortive progression. I mean, they stay like in the same place and are the ones that are in the classification are called abortive. So another example of the natural history of the hemangioma, this is a mixed one with the 2 components, and you see that there's just a little scar here, and this is another one that was this size, and you can see superficial one with a little residue. How the hemangiomas are there? Why do they appear? So there are a lot of hypotheses, and the one that is more accepted is there is a moment of hypoxia in the tissue, in the fetal tissue, and then that triggers the vascular endothelial growth factor to activate the fetal stem cells to produce capillaries, endothelial capillary cells, to produce new vessels and pericytes and all the tissue that you see in the hemangioma. And when these factors start to slow down and low down, then that tissue is supplanted by converted into adipocytes. That's why you see in the hemangiomas, when it's all over involuted, you see that they have a residual tissue that is very soft, that looks like a adipose tissue. In this moment, when it's proliferating, it has the immunohistochemical of GLUT1, which is a glucose receptor positive, which is very characteristic and unique of the hemangiomas and help you to differentiate from other lesions. So what are the main differential diagnoses of the hemangiomas? In first place, the vascular malformation. Vascular malformation, the slow flow vascular malformation, because they look alike. And hemangioma, of course, when you start looking at them and you could, with the time, make the difference. If you observe very closely, you see that the color is not so bright, it's not so red, it's more like a wine color, and the aspect is different than the hemangioma. And the baby is born with the lesion already, with the macule, and it persists all his life, all the life of the person. The vascular malformation is like a birthmark that stays all the way, all right? And then you can have other vessels involved, like, for example, lymphatic, and then you have these huge masses from the birth, from the moment the baby is born. You already see the huge mass, and it stays all the life. This is a lymphatic malformation, a venous malformation, lymphatic macrocystic malformation. And the other lesion that you have to make differential diagnosis is the congenital hemangioma. As the name says, it is a congenital. I mean, the baby is born with these huge lesions that rapidly grow and disappear. How do you differentiate? Because they are GLUT1 negative, and these are tumors that have to be with mutation on this proliferation way, which is the GNAQ. So you look these babies that grow very fast, and then they leave this tissue that looks like when a hemangioma, a true hemangioma, has involuted completely, but do it very fast. Other lesions are the another tumor, vascular tumors, like angioma and caposiform hemangioendothelioma. The difference symptomatically, the baby sometimes is irritable because these lesions hurt. They cause pain to baby. And when you touch them, they are very indurated. Some of them are very hard, like the hemangioendothelioma caposiform. They are very hard. You have to make also a differential diagnosis with angiosarcoma. But you take a look, and this is completely different as infantile hemangioma. So as in review, you say that the diagnosis is mainly clinical. I mean, we have a very high suspect of hemangioma when you see the clinical picture. But you can also add to your diagnosis another way, imaging diagnosis with the ultrasound that you can do with Doppler in cases of deep hemangiomas that can be confused, or multifocal if you want to assess another organs because they have other hemangiomas, for example, the liver, or another lesions that are not very suspicious of hemangioma, and you would like to see the vascular flow. The MRI is very important for segmental, facial, or lumbosacral infantile hemangiomas because you have to evaluate for Sáenz syndrome or lumbar syndrome. And echocardiography, as we saw in our case, we had to do it because we thought of a Sáenz syndrome and we wanted to know if the heart was okay. So we do it to, rule out cardiac anomalies. And a spine MRI when we have the lumbosacral hemangiomas with the skin market. And also we wanted to detect a spinal dysrhythm, which is associated with these hemangiomas. And also another thing that sometimes we do are the laboratory tests, especially the thyroid function test, because we know that in large or multifocal infantile hemangiomas, there is a risk of consumptive hypothyroidism. So we have to perform that test And also if we have the suspicion of Cassava-Mary phenomenon. You know the Cassava-Mary phenomenon, we need to know how is fibrogen, platelets, to see if there's consumption of these elements in huge hemangiomas or if there is a huge hepatic hemangioma. We rarely do histopathology in these lesions unless we are suspecting of another vascular tumor or malignant vascular tumor. But if we do, or if we have a vascular malformation, especially in deep hemangiomas, that we are not sure if it's a vascular malformation or a deep hemangioma, so we could perform immunohistochemical of GLUT1, but we don't have it really in our low resources setting in our hospital, so we never really do it. We have to base on clinical aspects for the diagnosis. So as we saw in our case, we have to diagnose and we have to make sure this baby didn't have a Faces syndrome. Faces syndrome is a rare, complex neurocutaneous disorder that affects multiple organ systems and is most commonly seen in infants with large facial hemangiomas, as you see the very good example of Doreen. And why is it called like that? Because it's an acronym that captures its key features. What are the key features? Posterior fossa, brain malformation, especially in the cerebellum, Dandy-Walker malformation. Hemangioma, large segmental hemangioma, as we saw. Arterial anomalies, abnormal developmental of cerebral or cervical arteries, which may affect blood flow. Cardiac defects, congenital heart issue like coarctation of the aorta or septal defects. Eye abnormalities, structural defects such as coloboma, optic nerve hypoplasia, or retinal vascular anomalies, as we had the ophthalmologist in this baby. And in some cases, the sternal defects that are cleft sternum or supraumbilical raphe included when the acronym is expanded to Faces, as we saw here. So that's why it's called Faces. Don't forget this syndrome. It's very important. And it's the dermatology that always suspect this. Is the one that give the pediatrician the idea, be careful because you can have this Faces syndrome in front of you. You have to study. That's why you have to know about these cases, because you are the one that have to direct the studies the pediatricians have to do. So the diagnosis, as I told you, as we did with this case, is based on the clinical findings and the imaging. MRI, echocardiogram, ophthalmologic exam, and of course, the management always requires a multidisciplinary team. You have to start working as a team, as members of good team for these vascular complex lesions. So we have this another case of our hospital a long time ago. Look at the disfigurement this lesion caused because it was very superficial and grew really fast, that almost destroyed all the lips, as you can see here. And this time we didn't have propranolol. That was the time before propranolol. And in the area of sacroiliac area, we have the lumbar syndrome that goes from lower body hemangioma, urogenital anomalies, myelopathy, bone deformities, anorectal malformation, and renal anomalies. Now we know that depending on the localization of the hemangioma is the association of the anomaly inside the organs. So you have to perform a good MRI of the pelvis, depending on the lesion, on where it's located. And there are another high-risk features, location-based risks. For example, periorbital, you have to be very cautious because it may impair vision. You have to tell pediatricians, be careful with the lesion. The area of the burr area associated with airway hemangiomas and potential breathing issues. The area of lips, neck, and diaper area, because they are prone to ulceration. You have to be very careful, and they cause painful wounds, as I would tell you. Nose, ears, breast in females, they cause disfigurement, very severe, and they last all life. And of course, developmental anomalies. And in the lumbosacral, as I told you already, we have to study the spinal or genitourinary anomalies. And the size of the hemangioma and the number is also important. So the large lesions with are more than 5 centimeters on face, scalp, or more than 2 centimeters, they have high risk of scarring and structural anomalies. Sorry. So you have to be careful with large lesions. And when they are 5 or more cutaneous hemangioma, you have to be aware of hepatic and liver involvement. And this could lead to heart failure. You have to be careful, heart failure and the hypothyroidism, as I told you. And there are the subtype risk, the segmental hemangioma, again, to not forget, and mixed or deep hemangioma, they have a greater risk of ulceration and recurrence. You have to be very careful. So ulceration is amazing, but causes a lot of pain in the babies. And it's very sad because then you don't have many things to treat these cases. You use the propranolol, you have to use it in very low doses, all right? The propranolol in hemangiomas with risk of ulceration, because if you give a very high dose, it makes it more ulcer, all right? So the last papers and the last studies said that you have to use low dose, less than 1 milligram per kilo for that. We will see it in the treatment. So what are the signs of that hemangioma is gonna ulcerate? There's a pale area, a tenderness, and these lesions, of course, they have secondary infection, and they always leave a residual scar. And it's very sad because some of the ones that the hemangioma that ulcer are the ones in the lips, so they leave a very bad, as you saw the other case, a scar, and also in the genitals and in between the napkin area. So you have to know when to refer as a pediatrician, when to refer, early referral to this patient, and work together with the team, with the dermatologists, radiologists, etc. Especially if before 1 month of age. Remember that the growth occurs in the first 3 months. So we have to 3 to 4 months. So you have to be very fast to treat if they are located. As you see, this little girl, she is already 3 years, 4 years, and still had the lesion that destroyed completely her, a real hair mama here. So there's no way you could, it came late to the hospital, so we couldn't do too much. It's already a scar there. So, and when it's needed, the study, you have to try to perform the imaging to diagnose the anomalies that can be together with the segmental lesions. So the propranolol is the first line treatment for most high-risk hemangiomas. So how do we do it? We do it with oral propranolol. I personally don't have experience with nadolol, but if there are papers of nadolol, I use propranolol, and it's the gold standard. And typically we give 2 to 3 milligrams per kilo per day, and we divide it into 2 or 3 doses, which makes it very easy for mothers to give it. The duration is variable. Sometimes it's 6 to 12 months. Sometimes when you think it's over and you stop the propranolol, and you can observe that the hemangioma starts growing again, and you get very, very depressed. Oh my God, what happens? But as soon as you give it back again, it starts stopping growing again. So you have to monitor blood pressure, heart rate, blood glucose, especially infants. You have to be aware of babies that suffer from asthma, because if you give them propranolol, you could give the asthma crisis. So you have to, in a clinical history, ask the family if they suffer from asthma. In very tiny hemangiomas, they are focal hemangiomas, you could use timolol gel, 45%, or drops, which is another beta blocker. But you have to apply directly to the hemangioma. Little thin, usually they are thin lesions and not ulcerated, because the preparation usually comes with gel, and it could pain if you put an ulcer, ulcerated hemangioma. Another alternative medications, oral corticosteroids. We still use oral corticosteroids, prednisone especially. In our low resources settings, when sometimes we don't have to do, we don't have a way to do MRI, but we have a very high suspicion of artery anomaly in the brain. Sometimes we get scared of using propranolol. But we start with oral corticosteroids while we try to do at least one ultrasound to make sure that, you know, there's nothing big that we could have a stroke in a baby. So, but now there are papers that have made them easier and say that you can start propranolol in low dose and it's safe. So you can use it still. But sometimes if you are afraid, you can use still corticosteroids. And sometimes intralesional steroids, if you have a very big mixed lesion and you like to, you know, if it's going to cause any deformment or any scar or something, you can do steroids intralesional to make it grow faster and finish the growth easier. And other agents that are not anymore used are the interferon alpha, vincristine, sometimes in a settings when we have cassava merit phenomenon and we don't have anything else, we don't have sirolimus, we could use vincristine, but those are complex cases that we work with interdisciplinary way. And then other treatments like laser and surgical options, for example, post-dye laser or surgical excision in cases where they are already grown. I mean, this in the time when they already finish the grow and everything. After years, we can use post-dye laser or surgical excision. There is a very isolated focal lesion that we can do a surgery, we do it, but very isolated. And when to refer, as I told you, very easily, very early, is recommended for facial or airway infantile hemangiomas or ulcerated lesions, or those lesions that are causing functional impairment, vision or feeding. And as I repeated again, large or segmental hemangiomas with risk of face syndrome, you have to work together. You have to make your team to work with you, and then you take the direction of the team because you are the dermatologist, you are the one that made the diagnosis. So in some, you have hemangiomas that are diagnosed as clinical, and then you take the localization and the evolution. Sorry, this is in Spanish. And then you perform the histological study and the immunohistochemical study in cases, I mean, in very cases that you are not sure you are in front of a hemangioma. It's very rare. And then you need to do the radiological evaluation and ultrasound evaluation to confirm. And of course, in those that need to do an MRI are the ones that are segmental, facial, large hemangioma, and located in the lumbar section. I have all the references. If you wanted to have, I can give you all the references that in some they have resume all this class for you today, and I can give it to you. So I would like to thank my mentee, Doreen, for this exceptional case that she got it. It's really a very rare case, and she could learn a lot from that, and to bring it to you and to make this webinar with this theme that I love, which is vascular anomaly. And I hope to receive all your questions this way. And thank you for your attention.
Wow, great presentations, both of you. Thank you for sharing your knowledge. We do have a couple questions in the chat box here. If anyone has additional questions, please enter them below and we can go through them. The first question, and this isn't directed to this can be for both of you, mostly about treatment. What treatment options do you suggest when a hemangioma is in a cosmetic or sensitive area, but shows signs of early involution?
Well, can you hear me? Yeah.
Yes.
Yeah. It depends the localization. You could use, if this is a tiny one, you can use timolol, right? You can use timolol topical, and it goes very good, especially at night, so the baby don't throw, don't move the gel and anything. It depends. If it is big, I mean, it's going to cause aesthetic problem. You start the propanolol because you don't want to let them grow so fast and destroy the area. All right. So that's the way. It depends the localization. Remember, there are risk areas that you have to be really fast. If there's an area that is not so risky, you can wait. But of course, as I was telling Doreen, in Venezuela, mothers want to give a medication. They want you to do something for that. They don't want to see the lesion on the baby. Even though that you tell them that it's no problem with a lesion that's going to disappear, they don't want to see that lesion on the baby. So you have to do something on that. So the use of the beta blockers, topical or systemic. Okay?
Great, thank you. Another question, and this could be for both of you. What advice would you give trainees when assessing and counseling families about hemangiomas that may or may not need treatment? So kind of jumping off of what you were saying, Dr. Sáenz.
Yes. You have to talk a lot of them. We have to convince them that they are going to go away, and they could leave a little scar that you can work on that at the end with laser or with something, even creams you can use to get the spot off. I mean, you can work with that, but you have to talk to them long time, because then if you don't do something, they go to another person, and maybe that person is not the best person, and it could do something to the baby that would leave a scar really, you know, like for example, cryosurgery. You can, cryotherapy was used long time ago, even for little ones. The pain that causes to babies, and the scar that sometimes leaves. I mean, you have to convince those parents not to do anything like that. You can give the timolol if they are small, or give the propanolol in case, but you have to try to convince them. Yeah.
Dr. Mapunda, do you have anything to add when the discussion amongst residents and trainees, since you recently graduated?
No, I have nothing else to add. But Dr. Ana Maria is right. You do need to talk to the mama extensively, like to explain what the problem is as best as you can, and then try to see if she's more inclined to needing treatment. Then you have to prescribe something, like we also would prescribe timolol, and then if she's understanding, then you can send them home without treatment. But then it also depends on the patient. Yeah,
these are great, helpful tips. Thank you. A couple other questions about treatment. Can you use timolol and propranolol at the same time?
It's really not necessary. If you're doing propanolol, you don't have to do timolol. I mean, it's nothing. I mean, you can see the response really fast with the propanolol. Sometimes I get worried when I don't see any response. I get worried because there are some hemangiomas. It's good that there are not so many that they don't respond to propanolol, to beta blockers. That's something that it's a matter of discussion in those meetings. There are few of them, not too many, but they don't respond to. So we have to do something else. But most of them, they respond well to propanolol. Yeah, so we don't have to use topical. I mean, no.
Okay. Great, thank you. We have one question asking a specific question about a case that they had seen for a baby with a hemangioma that's already causing respiratory distress. In this case, they had a facial lesion and it came in with DIB. I don't know what DIB stands for. If whoever put this question wants to put it in the chat, or you know this, Dr. Sáenz.
DIB,
Uh,
DIB, I don't know.
yeah, so this baby has a facial lesion and is causing respiratory distress.
Yeah,
Can you stick with propranolol alone, or is this where the
yeah,
multidisciplinary care is really
yeah.
important?
Yes, yes. Sometimes they are so aggressive that these kids need to be intubated or tracheostomy, so they could breathe while these lesions start going down. That's why you need to, in the very complex ones, you have to work as a team with these cases. But sometimes when they don't, or they cannot use propanol, you have to come back to steroids, and also you can use sirolimus too. They even it's not the first choice for hemangiomas, but you can also use sirolimus for complex cases, and or another drug that for those cases, sometimes terrible cases. Usually you get the suspicious when they are located on the neck. You have to be very careful. Or when the baby start coughing and have a stridor, you have to make sure they don't have a lesion there. We have got it, and thank God they have responded really fast, and we haven't had it to put them in the UT for the terrible cases, no. But in the reports, there are cases very terrible like that, and I have seen it in the meeting that they need to be managed multidisciplinary, yeah, to save their lives.
We have one question asking about what one of the most challenging patient cases with a hemangioma that you've treated. If you're willing to share a story or a patient case, that would be great.
Well, just last year, I might have one of my residents watching this webinar, I don't know, but Andrea, she was the one that had that baby with a facial syndrome, but she had 2 segmental facial hemangiomas. It's a very rare case with 2, just like the one I showed you, but that was a long time ago in my practice in the hospital. But this one was last year, and this baby was very, very scary because he had a stridor, laryngeal stridor. I don't know if you say it in English like that, and also the 2 plaques of hemangioma in both frontal and malar area, all the way to his eyes. I didn't put the picture because we're going to present it this year in our meeting, but this baby had a terrible edema in his both eyes. He couldn't open his eyes and also breathe very well. Thank God we started with prednisone because we did, having 2 hemangiomas, we were very scared. He had an anomaly in the cerebral arteries. So sometimes that can cause a stroke in the babies because they could be very thin and it could be a ischemic stroke. So we were very scared. And then in those days, there was a paper that said that there was no worry about using the propranolol in these cases. So we started doing, it was like a miracle. That baby did very well, and he could receive it and go out of the hospital. Now we just call him because of this webinar. I asked Andrea, how is it the baby? And he's doing very well. But we haven't seen because he's from the countryside of Caracas, Venezuela, so we don't see it very often. But it was very scary, very scary. That was very soon, last year.
Wow, thank you for sharing that case.
Yeah.
It's incredible to hear how common these are, but how challenging that they can be, and how much of a difference you can make with what seems like a simple medication, propranolol.
Yeah.
One of the last questions that I think we have here is, can benign vascular tumors like hemangiomas, once they're treated, do they have a chance of recurrence as a malignant tumor at that site?
No, no, there's no reports about that. Really. No, they are completely benign. And that's their behavior. I mean, they are completely benign. I haven't read anything about it. I will look at it, but because it disappeared completely. It's changed for adipocyte. It's like a adipocyte tissue. When they are gone, it's not anymore the same tissue. It's another tissue replacement. They're replaced by adipocyte tissue. So it's never a capillary or endothelial cells, not anymore. They are all gone. Yeah. And there are no mutations that are, known that could convert into malignant tumors there, right? Until the moment. So.
Great. Well, thank you so much for your engaged discussion and answering all of the questions today. Thank you, audience, for being involved and engaged and asking questions. Any last final words or advice that you'd like to give the audience here?
Doreen?
So no, I don't have any final words, but when I was presenting my case, I forgot to talk about all the parameters that we were checking every time the mama came to the clinic as follow-up with propranolol. Dr. Ana Maria has mentioned many of them, but you have to ask the mother if there's any history of loss of consciousness, seizures, if the patient has been turning blue, if there's difficulty in breathing. All of these are important questions to ask when they come in for follow-up, because then they will tell you if you missed something, especially in a setting where you were not able to do full investigations. Like in our case, we weren't able to do an MRI, so we weren't sure if the patient had any anomalies that we hadn't that we weren't aware of. So history is also very important, apart from all the investigations, but history taking is very important, and a full body exam every time the patient comes in for follow-up, I think is all I can add to the presentation. Yeah, thank you.
Yeah. Well, I would like to congratulate Doreen for the case and also to bring it to the webinar, because I saw that there was no vascular anomalies webinar before, so we have to do something. And it's a very growing field. It's amazing that I have been, going to these meetings a long time ago, and we were very few people. And we are very excited right now that in the World Congress of Pediatric Dermatology, there was a huge auditorium full of people looking at the vascular anomalies session. So that makes me very happy, because people want to know, want to learn. And this is a great opportunity. And I thank GlowDerm institution, also the training committee, for have these tremendous, fantastic ideas of bringing knowledge to people, and then you can hang it there and people can see it again. And it's very simple, my knowledge. I'm not a very, huge, but it's a very nice field coming. And, with the genetic advancements, this field has changed so much that is so interested that people get involved and get to know that. I'm very, very happy, really. So we have the next generation, like Doreen, is going to work. And I always tell that you are going to be the referral person in Tanzania for these missions, because it's very amazing, very fantastic to learn about this. Thank you so much for everything, for your invitation, Alexa and Becca, for your kindness always, your help. You're very nice. Thank you so much.
Well, thank you both. We really appreciate your time sharing your knowledge on this. For any announcements, where we have a webinar coming up on Sunday, July 20th. This is going to be a recording of the International Congress of Dermatology, with which Dr. Ana Maria Sáenz and Dr. Mapunda presented at. So we'll have the recording at the first 2 hours on Sunday, and then at 11 a.m. UTC afterwards, there'll be a 1 hour live Q&A session. So please join us on Sunday for this ICD webinar. We have the link in the comments below. But with that, this will be the conclusion of our educational webinar series for today. And please be on the lookout for further educational sessions. Thank you all.
Thank you. Bye-bye.
All right,
Thank you so
goodbye.
much. Bye-bye. Bye-bye.
Bye-bye.
Thank you.